Thank you.
Good evening, everyone. On behalf of TaskMed, I would like to welcome you all to Medcast Insights into Healthcare, a learning initiative by TaskMed. Today, it's a great pleasure to have with us Dr. Akhil Sharma, who is a professor at Department of Cardiology, King George Medical University, Lucknow, Uttar Pradesh. We welcome you, sir.
Thank you.
Sir, we look forward to hear from you on today's topic of discussion, Mexiletine and Unexplored Antiarrhythmic Drug. Over to you, Dr. Sharma.
Thank you. Thank you having me, our team. And it's definitely a very interesting topic we are going to discuss. And I think it may be helpful to manage our patient in day-to-day practice or in some unfortunate patient for him or her. We didn't have much options to treat these kind of patient. And in everyday practice, we are facing these kind of patient with very unexpected higher complication rate or death rate. And unfortunately, in any place all over world, we didn't have much uh, arms in our armamentarium to treat these kind of patients. And unfortunately, in India, the options are further limited, and we have to treat these patients with very limited resources. So today, I am going to discuss on the Mexiletine, a drug which we can say that we have another arm on our armamentarium to treat these kind of the patients who didn't respond what we have available with us in our emergency department. And now I will start to discuss today's topic with a case example. So this is a case of 56-year female who presented with the palpitation and breathlessness from 2 days. And at a time when she presented to our emergency ECG, done immediately on ECG, void QRS tachycardia identified. When we taken the history about the patient comorbidities, prior clinical history, not significant found. And immediately ECG done due to the history of palpitation, and ECG shown what QRS tachycardia. So as you all can see, it's a broad QRS tachycardia, rate approximately 150, and LVV type of the morphology, and we can very easily appreciate there the AV dissociation. We can identify P wave at the end of the QRS, and which not marry with each QRS. LVVQR morphology with flowing in the earlier QRS complex with AV dissociation. So our diagnosis is less or more confirmed as the ventricular tachycardia. And when we identified it's the case of ventricular tachycardia patient with us in emergency, so we uh, go forward to treat this patient as our standard protocol. We immediately given, because patient hemodynamic is stable, VP 110/70, heart rate, ventricular rate is about 150. So we given a trial with the IV amiodarone bolus, and fortunately patient reverted within 2 to 3 minutes, and we got this rhythm, which is the sinus rhythm, without much STT changes. We can identify there the ST coving and T inversion and B6, but there is no sign of any STMI or any coronary episode at a time of presentation. Patient didn't complain any chest pain, exertional in the angina, and any other thing. So patient treated with the amiodarone bolus, 150 mg, followed by the infusion. After that, we did the screening echo, which on which we can identify that the poor LV function, and without significant any valvular involvement, without significant specific regional valve motion abnormality. And we plan to evaluate further to rule out the ischemic pathology. Coronary angiogram done, and this shown the normal coronary. Now, further challenge with us that the patient is the label as the dilated cardiomyopathy without any prior history, and we should always confirm our diagnosis of idiopathic cardiomyopathy, or we have any other precipitating event, or they can be presented with the sudden palpitation in our emergency. It may be case of the chronic cardiomyopathy, or it may be some viral illness, some psychosis or tuberculosis, granuloma. So we have to rule out these kind of the pathology. So cardiac MRI advised the patient, and MRI showed there the biventricular inflammatory cardiomyopathy with extensive fibrosis. So our diagnosis now is LVEF about 30%, RV function mildly deranged, and patient has fibrosis with the inflammatory infiltration. So we suspect that the patient has viral etiology. It's a very common scenario in recent past. With this pandemic, we receive these kind of the patient routinely in our emergency. So in view that the patient has the inflammatory infiltrate with the extensive fibrosis, poor LVEF, so we started class 1 indicated treatment like the beta blocker and amiodarone, and patient hemodynamically stable. But again, is not fortunate enough. Again, develop hemodynamically unstable BT, which again shown broad QRS tachycardia and morphology again changed. And now patient presented with the broad QRS RBB type of morphology, and we can appreciate AV dissociation again in this ECG. So fortunately, rate was not too much at that time again. So we again try to manage this patient with the a conservative approach. But so we already used amidron. So we start IV lignocaine. Patient reverted fortunately. Again, ventricular tachycardia is a very common history, or I can say the story in our emergency department. When patient came and we tried the treatment, patient respond, but again developed the arrhythmia again and again. This happened, and at the time and recurrence increased with the time, response of therapy decreasing. So patient again developed electric cardioversion with 100 joule done successfully. Medical therapy with the dose of propranolol, which increased oral amidron started. Provisional diagnosis of acute myocarditis with pleomorphic ventricular tachycardia with LV dysfunction kept. And as we all know, the acute myocarditis patients are very notorious in the form of the recurrence of ventricular tachycardia, response of the different available therapy for this tachycardia, and these are the very poor responder for the therapy. So when we continue the Cardron 200 mg TDS over the time, we monitor patient all the parameters like the renal function, electrolyte, potassium, magnesium, are within the normal limit. We rule out the sarcoidosis, the ACE level done, CT test done, X-ray, and whatever we can do for the tubercular granuloma. All these investigations done which within the normal limit. Patient managed on the oral amidron with beta blocker, and again typical story, as we all know that with the Cardron, patient develops gradually the bradycardia, QT prolongation start, and with the normal all electrolyte without any other QT prolonging drug, patient taking the every 12 hourly done the ECG for these kind of the patient, and calculating the QT interval, and we mention their QT interval on their case sheet as well as the ECG, so we can identify what is the QT interval, and we regularly check what molecule, what drugs, and any electrolyte imbalance, and any other thing which can prolong the QT for the patient, and we put always a check on that. But unfortunately, this is a patient who is treated with the amidron, and amidron is necessary to control ventricular tachycardia, which fortunately control it, but unfortunately decrease the rate. Sinus bradycardia develop. Patient rate is about 60, 62, and QT is prolonging, and you can all identify very clearly QT is grossly prolonged. So we have no option except that to stop the oral amidron. So we stop it. And after stopping the amidron, again ventricular tachycardia start. We didn't have much option, as I earlier mentioned that in our armamentarium very few options we have. So Now we decided to overdrive the ventricular overdrive done for the patient with temporary wire. And again, it's another option is that we want to give the sedate the patient. We put patient on the thoracic epidural anesthesia, and after all these treatment, it's not very fruitful. So further sinus bradycardia noted with the after sedation, atropine given, patient didn't respond. So we put a temporary pacing in atrial side and pace with the coronary sinus. Now, what option we left? So we used amidron, which caused the prolonged QT, and we used beta blocker. We used the thoracic epidural anesthesia. We sedated patient, and we given the temporary pacing and atrial pacing to decrease the to improve the heart rate. So bradycardia induced ventricular tachycardia can be stopped. As we are all aware that the patient has the infiltrative inflammatory myocarditis. So we also discussed the catheter ablation, but we all know that the in myocarditis situation or in diffuse fibrosis with inflammatory infiltrate, catheter ablation not much help to us. So we just put it in our background of mind that we can or use the option, but we all aware that it's not helping us, going to help us. So without any delay, we discussed with the patient that we have the last resort of therapy is the sympathectomy. So we can discuss the patient to give for the minimally invasive bilateral thoracic sympathectomy, and which given some relief, but ventricular tachycardia is not completely resolved. Patient developed in between, and DC. So we didn't have any option without except the overdrive pacing, but it's not terminating with overdrive pacing. We have to give in minimum threshold DC cardioversions to our patient. And we all know that with the increasing DC shock, with every DC shock, the patient mortality is going to increase, patient LV dysfunction is going to further deteriorate. So it's a very unlimited options left with us, and we didn't have any option to sedate patient with anesthesia, and we intubated with and given the general anesthesia. So fortunately, at last, because we have to stop the amidron, now we consider other options. We already used linocaine, and now we started tablet magnesium to our patient over and over the beta blocker. And we because we are following our patient day by day, and some QT is of patient is normalized, so we start low dose amidron because it's the last resort with us. So we don't have any other option to treat our patient, so we take this risk at the time to start amidron and meglitine. Over the next 3 day, BT become infrequent. After 48 hours of BT free period, dual chamber ICD inserted, and I think patient is fortunate enough that our therapy worked, and definitely the time which we by the all these intervention may some inflammation subside, irritability decrease, so patient responded, and after decrease or when there is 48 hour of the VT3 interval, we implanted ICD with atrial pacing at 70 rate and optimal dose of amidron, beta blocker, and magnesium given simultaneously, and patient discharged in stable condition. So this is the success story for our one of the our patient, but we not always some fortunate enough to save our all patient, and it may end in something else and very unfortunate end of the story. But sometime very some molecule or some of our effort pay off and patient can be saved. So this is a specific case of the BT storm. It's quite normal in current pandemic. Viral myopathy is showing the many cases of myocarditis in this pandemic, and it's definitely a very difficult situation to manage. So why we can manage how we can manage our BT storm patient, how we can approach these, and definitely it's a very unfortunate and very dreaded condition. But with the team effort, with the patients, and with available whatever we have in our armamentarium, we can save much of the patient with a systematic approach. So VT storm in a patient without ICD can be defined as the two or more hemodynamically stable BT within 24 hours, or BT recurring soon after termination of another BT episode, sustained and non-sustained BT resulting in total number of ventricular ectopic greater than the sinus beat in last 24 hours. In patient with the ICD, most widely accepted definition of electric storm is the three or more appropriate therapy for ventricular tachyarrhythmia, including anti-tachycardia, pacing, shock within the 24 hours. However, when we define the patient who already had ICD, it's a very difficult because it's not include all the patient who didn't identify by the ICD or the patient who terminated with the anti-tachycardia pacing. Clinical syndrome of electrical storm. It's a vulnerable anatomical substrate. Usually patient develop who had the anatomical substrate, like our patient who had the inflammatory myocardium with the fibrosis, and some another event happened, some myocardial injury or some electrolyte imbalance like the triggering event happen, and patient develop ventricular premature complex which progress to the ventricular tachycardia. Determining the cause of electric storm is very essential, because we have to treat our patient according to the precipitating etiology as well as the causative etiology. And when we come to the ventricular tachycardia morphology, we can have two types, monomorphic or polymorphic of the ventricular tachycardia, which may further divided in the torsidy point of bidirectional BT. Monomorphic BT can be divided in the non-sustained, sustained, insufficient, and BT storm. When we come to the etiology of ventricular tachycardia, we all know that the ventricular CAD is the most common pathology for the structural heart disease patient, and it's almost count about the 75% of the all ventricular arrhythmias. And when we consider cardiomyopathies like the DCM, SCM, and ARVD, 15% of patients contributed by this. Other causes are rare, like the inherited cardiomyopathy, channelopathy, valvular heart disease, and rare causes like the genetic disorder. And when we come to the management of the VT patient in heart rhythm volume 2014 journal published the approach to how we can manage our patient of the ventricular tachycardia. So it's a very standard guideline. Go for the rule out the structural heart disease, risk factors, symptoms, and non-cardiac disorder that can affect the heart, like the syncope, family history of SCD, family history of the structural heart disease, physical examination, echo, and electrocardiogram to identify different morphologies of ventricular tachycardia or predisposing condition. Exercise testing, especially in young males who reported the syncope on effort. Imaging of coronary arteriography, or like the MR, CT, what required according to the specific pathology. If the abnormal basic evaluation structural heart disease identified, then we have to go for the advanced imaging MRI or the CT coronary angiography. If no structural heart disease, we have to manage patient accordingly. Ventricular tachycardia etiology, structural heart disease, idiopathic BT can be divided in the outflow tract BT, fascicular BT, or papillary muscle BT. If primary arrhythmogenic syndrome, genetic syndrome identified, they can be divided in the Brugada, ARVD, long QT syndrome, short QT syndrome, or cataclysmic ventricular tachycardia. Underlying structural heart disease like the ischemic cardiomyopathy or non-ischemic causes like the idiopathic dilated cardiomyopathy, ARVD, SCM, cardiac sarcoidosis, and Chagas disease. And I want to specific attention on this cardiac sarcoidosis. These are the very, I think, is a frequent diagnosis, and which usually missed in our emergency department and clinical evaluation. and we have to give all the attention to identify tubercular granuloma in our continent specifically and cardiac sarcoidosis, and we have to have identified or evaluate each patient of the structurally normal heart who presented with the monomorphic as well as the polymorphic ventricular tachycardia. So when we come to the management, we have to have opt first is the medical therapy. Definitely, we didn't have very effective therapy in form of medical medicines, but it's a very easy to give this therapy in emergency department. It's have effect, but definitely, except the beta blocker, we didn't have mortality benefit with all of these therapy. And when it's failed, we have to go for the ablation therapy recommended as the class 1 indication for catheter directed or surgical. And ablation therapy, we it's very effective, specifically in the scar ventricular tachycardia, which happen usually in ischemic cardiomyopathy or ischemic heart disease patient, where the localized scar formation generate these ventricular arrhythmia, and catheter ablation successfully treated this condition. But when the generalized pathology is involved, like the inflammatory disorders, ablation therapy is not very effective. Device therapy, defibrillator and implantation, as well as the anti-tachycardia therapy. We all know that, these are the no therapy to treat the ventricular tachycardia. They are only terminating the ventricular tachycardia, but not correcting the pathophysiology. So this is therapies which terminate ventricular tachycardia, but we have to treat our patient pathology, or we have to suppress ventricular tachycardia with the medical as well as the ablation therapy. So how we can manage our VT storm patient, correct any of the reversible cause if possible. So patient who presented with the ischemic ventricular tachycardia, we have to correct ischemia as soon as possible. Electrolyte imbalance, every patient presented with the ventricular tachycardia should be evaluated for the electrolyte like the magnesium and potassium. If there are any derangement, should be corrected as soon as possible. And patient who presented in our emergency should be corrected for the fluid management, and if any reversible pathology identified, should be managed very promptly. Early pharmacological sympathetic blockade with the help of beta blockers should be started if it's not contraindication at the time of presentation. Deep sedation and intubation with the GA may help sometimes. Antiarrhythmic drugs like the codron, mexiletine can help. Lidocaine. Reprogramming, if patient already received ICD, reprogramming should be done to minimize the shock. And neuroaxial modulation as well as the catheter ablation may be considered. So when we come to the antiarrhythmic drug, definitely it's a therapy which can be used very easily, and it can be given as a first line management therapy, but we have to understand that every antiarrhythmic therapy has their contraindication as well as the side effect. They can precipitate ventricular arrhythmia again, they can precipitate AV block, sinus pauses, or bradyarrhythmia. But advantage that they are inexpensive, very rapidly can be used, can be accessible at any time of the any place or any time, and it may help to reduce the ICD shock. Implantable cardioverter defibrillator, definitely class 1 therapy to prevention of VT and V-wave, mortality benefits shown, and does not prevent VT happening, but it's decrease it's help to terminate that, but not prevent the happening. And with every increasing shock, mortality of patient increase. Catheter ablation, as I earlier discussed, the wonderful therapy, and but has limited success. Sympathetic denervation only for reflectivity had some limited evidence of benefit, but not very effective therapy. And now come to the antiarrhythmic drugs. We all aware with the Vaughan-Williams classification. We have the class 1 drug, which labeled as the sodium channel blocker and further divided into A, B, C. In class 1A, quinidine and procainamide. Class 1B, lidocaine and mexiletine, we have to discuss. And class 1C is the flecainide and propafenone. Class 2 Beta blockers, class 3 is the potassium channel blocker like the amidron or sotalol, and class 4 the calcium channel blocker, diltiazem and verapamil. So I would like to discuss specifically the class 1B lidocaine and mexiletine, and it's indicated in post-MI ventricular tachycardia, long coitude syndrome, especially the Q3 and cordron. So pharmacological characteristics of different antiarrhythmic drugs. Amidron, as I earlier discussed, give IV bolus of 300 milligram if patient is have VF, unstable VF or VT, and if patient is stable, give 150 milligram bolus with continue the 1 milligram per minute infusion of 6 hours, and those will half for the next 18 hours. And when patient is stable, switch over to the after the infusion for the per therapy 400 milligram QID to TDS, and try to decrease the therapy when the patient is stable over the follow. Again, importance is this can lead to the slowing of the sinus rate, QRS prolongation, QTC prolongation, and AV nodal refractoriness increase, which also increase the defibrillation threshold. Adverse effect, long list of the coronary adverse effect I'm not going to discuss, but their important is the hypotension and development of the torsity pontis or increase of the QT segment and QT interval. Lidocaine can be given as the 1 gram per kg, 1 milligram per kg bolus, and followed by the infusion. We can repeat multiple bolus, and infusion can be continued till the patient is stabilized. Important side effect again, bradycardia, hemodynamic collapse or AV block, delirium and psychosis are another to mention. Again, metoprolol or beta blocker, we all know we can give IV with the 5 milligram bolus up to the every 5 minutes up to the 3 doses. After that, the oral up to 200 BD. And again, the complication not very important, but it may cause the AV block, hypotension, dizziness, fatigue. Mexiletine is another molecule we have to discuss, and this is the new molecule in our armamentarium. It may be considered as the oral form of the lidocaine. We should start as the oral 150 to 300 milligram in divided doses, and it's had no marked effect on the most interval QTC, slightly shortened, not increased. So we can have this option when we given amidron or patient develop the QT prolongation or any other molecule like anti-allergic medications and antibiotics which increasing the QT. We can use this molecule with them with the help of the beta blocker. It can improve the QTC interval. Side effect not very important, heart failure and AV block as earlier mentioned, lightheadedness, tremor, GI side effect can be noticed with the mexiletine. So side effect profile is not very significant. These are the very safe molecule, can be used in each and every patient, and specifically in the QT prolonged QT when QT is prolonged. Proconamide, again, we can use IV with the loading dose of 10 to 70 milligram per kg at the 40 to 50 milligram per minute infusion rate. QRS again prolonged. So except the beta blocker, all antiarrhythmic drugs increase the QRS, and mexiletine can shorten or it's not increasing the QRS duration. Sotalol again QTC prolongation happens, so we could not use this drug in the patient who had QTC prolongation or torsity pontis. So mexiletine approved for the ventricular tachycardias, and DGCI also improved this molecule, and it's recommended as a class 2B indication in the ACC as well as the HRS guideline. ESC also recommended in 2014 guideline to treat ventricular arrhythmia with the mexiletine as a class 2B indication. It also recommended for the patient who already had ICD to decrease the episode of DC cardioversion. So class B, how it's work, we all know that they strictly similar to the lidocaine but orally active, inward sodium current, reducing phase, zero of the action potential, Site of action is Purkinje fiber, and though the effective refractory period decrease, result in the increase in the effective refractory period and action potential duration ratio. So ultimately, it's help to decrease ventricular irritabilities and conversion of the stable ventricular tachycardia. Electrophysiological properties similar to the eloquent patient with the normal conduction system can have the minimal effect on their conduction, AV conduction, as well as the QTC duration. No QRS duration as well as sinus node conduction minimally inhibited. Patient with pre-existing conduction defect, depression of sinus rate may be a prolonged sinus node recovery time due to the increase in the ERP. Mexiletine, when we compare mexiletine with the other antiarrhythmic drugs, you can see that the effect of the mexiletine on the different electrophysiological parameter is minimal when we compare to the other. That amidron is the most commonly used drug in emergency department. It decreased the sinus node rate. It had increased the AV nodal refractory period in PR interval variably affected QRS duration increase and QTC interval increase. So it's definitely amidron give benefit to our patient, but when side is studies in the patient, post-MI patient with amidron given, it's increase the mortality and definitely it's not decreasing mortality to our patient when we treat with the amidron. And in therapy with the amidron, QTC prolongation is a significant and important issue we have to address, because most of the patients of post-MI ventricular tachycardia or BPC has polypharmacy, and which may lead to the further prolongation of QTC or electrolyte disbalance. When come to the disopramide, flecainide, and flecainide, all are the drugs which have the effect on all electrophysiological parameters. Some increase the QRS duration, some has the sinus node or AV nodal conduction defect. But mexiletine or lidocaine are the molecule which didn't have any significant effect on the different electrophysiological parameters. So this is the molecule which is at least safe, efficacious, not very much efficacious, but at least as a point of consideration, and it's not going to harm our patient. So in emergency management, it's important. We have to treat our patient of ventricular arrhythmia, and we also want that the patient did not develop again any arrhythmia due to the molecule which is used to the treat. Definitely no effect on the hemodynamics also, no significant negative inotrope. When we consider the antiarrhythmic drug, they usually are negative inotropic. They decrease the blood pressure causing hypotension. They block the sinus node or AV node, so decrease the conduction. So mexiletine didn't have any effect. Mexiletine pharmacokinetic, very impressive absorption, well absorbed about 90% from GI, 50 to 60% bound with the plasma protein. And unlike lidocaine, its first pass metabolism is low, elimination approximately 10% executed until by the kidney. In normal subject, plasma elimination of life is approximately 10 to 12 hours. Doses, as I earlier mentioned, we can administer with the food or antacid, initiate with the 2 milligram, 200 milligram every 8 hourly. You can increase the dose or you can decrease according to the patient status, and can decrease up to the 50 to 100 milligram over the follow-up. How we can start mexiletine? When rapid control of tachyarrhythmia is essential, patient is unstable, loading dose of 400 milligram after 8 hours. After 8 hours, 200 milligram can be started TID or continuous as per the chronic treatment. If patient is stable, when the arrhythmia decrease, you can decrease the dose. When rapid control of tachyarrhythmia not essential, then you can start with the 200 milligram TDS, and you can increase the dose or you can decrease the dose over the follow-up. 300 milligram every 8 hourly, after that the 400 milligram. When patient had controlled their symptoms, you can decrease the doses. Contraindication in patient of cardiogenic shock, pre-existing significant AV block, or patient who require pacing for the blockage, conduction block. Adverse event, Mexiletine is generally well tolerated. I already discussed reversible gastrointestinal on effect with the tremor, ataxia, or nausea, vomiting. Usually, these are the very limited effect and reverse when we stop the therapy. So this is a flow diagram from the ACC AHA guideline 2018, how we can manage a patient of the sustained monomorphic ventricular tachycardia. First, we have to identify the upper ventricular tachycardia patient. If hemodynamically unstable, go for the cardioversion and start the CPR or the basic life support. If patient is stable, then go for the ECG and physical examination. Quickly consider disease which is specifically cause ventricular tachycardia. If patient has a structural heart disease, by the echocardiogram as soon as possible, and patient diagnosed as a case of structural heart disease, then go to the cardioversion. After that, if it's not successful, go for the procainamide, amiodarone, and mexiletine. If BT terminated, uh, continue for therapy guided the underlying heart disease and manage. And if we're not terminated, cardioversion again and again. And if not effective, then go for the sedation or general anesthesia, sympathectomy, or add another molecule which you have in your armamentarium. If patient did not success and BT terminated, didn't submit, then catheter ablation is the last resort. And patient didn't have any structural heart disease, then go for the typical ECG morphology, try to identify the outflow tract ventricular tachycardia, and try if it's diagnosed as the verapamil sensitive ventricular tachycardia or outflow tract ventricular tachycardia, verapamil or beta blocker. So we use, if it's not effective, then cardioversion, and if we identify to recurrence of these kind of the outflow tract ventricular cardiac catheter ablation can be considered. So now summarize the Mexiletine as an antiarrhythmic drug indicated in sustained ventricular tachycardia, agent with moderate potency, definitely I discussed, with minimal side effect, appreciable safety in LV dysfunction in patient who has the QT prolongation, reversible or non-lethal adverse effect, class 2B recommendation by the guideline of the management of the ventricular tachycardia, can be used in add-on therapy on amiodarone, sotalol, or beta blocker, and patient who had already ICD. So I just want to specify here that we can use this molecule with any of the already used antiarrhythmic drugs. We can use in patient who had the QT prolongation, already had QT prolongation, or who developed the QT prolongation during the treatment of the another antiarrhythmic drug or electrolyte imbalance. We can use this molecule for the long QT syndrome, like long QT syndrome, especially 3. It's shown efficacy in long QT syndrome type 2 in very small trials, but it's promising result. So we can use this therapy in patient in which the long QT is prolonged, and we can't use amiodarone, sotalol like molecule due to the prolonged QT interval. So it is a molecule which can be used with the beta blocker in patient who have the QT prolongation. The management of ventricular tachycardia includes 3 major modality: medical, device, and ablation, and hybrid therapy usually required. One therapy is not always satisfactory and successful. It may be a challenging therapy, and it may be need individualized approach. One size did not fit for all. We have to manage patient. If patient has the high risk of polymorphic BT, ICD should be first line. Catheter ablation considered specifically for patient who had scar BT, and medical therapy is acceptable for minimally symptomatic idiopathic BT and low risk group of the ventricular tachycardia. Thank you for your patience listening, and I am very much happy to answer if you have any question and query. Please.
If there is any query, participants can put their questions in the Q&A box.
Do we have a participant or?
Yes, sir, we are having participants.
Yeah, I'm very much happy to if any question put from my audiences. So it give me idea that somebody is listening. Do we have any questions?
No, sir. I think we can conclude the session. The session was really
Yeah.
insightful.
Yeah. Thank you very much. I just want to say that it's a molecule which should be used in emergency department. We should give at least a milder potency of the option, but we should try this molecule and we should give therapy in patient who didn't have any other option. And usually it's happen in emergency department when we try to patient manage with the beta blocker or amidron and we didn't have any other molecule to treat these kind of the patient. So this is the molecule which can be improve outcome of our emergency department patient, and we should have this molecule to our emergency management armamentarium. Thank you very much.
Thank you, Dr. Sharma, for joining with us today. It was really an insightful discussion for us as well as for our listeners. And I would also like to thank all the doctors for being with us and for their active participation during this. Thank you and have a great day.
Thank you very much.